Swasthya 365 Day Project. I am here with you to discuss about protein energy malnutrition. Protein energy malnutrition is a major public health problem in India. This affects the child as most crucial period of time of development, which can lead to the permanent impairment in later life. PEM is measured in terms of underweight, low weight for age, stunning, low height for age, and wasting, low weight for height. The prevalence of stunning among under 5 is 48% and wasting is 90.8%, and with the underweight prevalence of 42.5%, it is the highest in the world. According to the World Health Organization, protein energy malnutrition refers to an imbalance between the supply of protein and energy and the body's demand for them to ensure optimal growth and function. Protein energy malnutrition accounts for 22% of burden of disease in India and adversely affects the economical growth of country within the estimated adult. The productivity loss of 1.4% of gross domestic product. Etiology, the social and economical factors, biological factors and environmental factors are lack of breastfeeding and giving diluted formula, improper complementary feeding, overcrowding in the family, ignorance, illiteracy, lack of health education, poverty, infection, familial disharmony, and role of free radicals in aflatoxin damage the livers, giving rise to the kwashiorkor. Age of host. Infant and young children whose rapidly growth increases the nutritional requirement. Pregnant and lactating women. Elderly can also suffer from protein energy malnutrition due to the alteration of GI system. Clinical presentation depends upon type, severity and duration of dietary deficiency. Types: kwashiorkor, protein malnutrition predominant, and marasmus, deficiency in calorie intake. Marasmic kwashiorkor, marked protein deficiency and marked calorie insufficiency sign present, sometimes referred to most severe form of malnutrition. We move on to the kwashiorkor. Kwashiorkor, Williams first used this term in 1933. It refers to an inadequate protein intake. Kwashiorkor, also called wet protein energy malnutrition, and it is a form of protein energy malnutrition characterized primarily by protein deficiency. More recently, micronutrient and antioxidant deficiency has come to be recognized as a contributory. Usually appears at the age of about 12 months, while breastfeeding has discontinued, but it can develop at any time during the child's life. It causes a fluid retention, that is edema, dry, peeling skin and hair discoloration. Kwashiorkor caused by insufficient protein consumption but with sufficient calorie intake, distinguishing it from the marasmus. Kwashiorkor child failed to produce antibody following vaccination against the disease including diphtheria and typhoid. Symptoms of kwashiorkor: changes in skin pigment, decreased muscle mass, diarrhea, failure to gain weight and grow, fatigue, hair changes, that is changing color or texture, increases in more severe infection due to damage in immune system, large belly that sticks out, lethargy, and loss of muscle mass, rash, shock, swelling, puffy eyes, moon face and anemia, hepatomegaly, and edema of legs and lower trunk, ulceration of lower limbs. Next is marasmus. It is a form of severe protein energy malnutrition characterized by energy deficiency and wasting of muscle and tissues. Marasmus usually develop between the age of 6 months to 1 year in the children who have been weaned from the breast milk or who suffer from chronic diarrhea. Symptoms of marasmus: severe growth retardation, loss of subcutaneous fat, severe muscle wasting, child looks thin and limb appear as a skinny and bony, and wrinkled skin, bony prominence, associated vitamin deficiency, failure to thrive, frequent watery diarrhea, dehydration, temperature is subnormal, and muscles are weak, fatty infiltration is absent. Marasmic kwashiorkor. a severely malnutrition child with feature of both the disease. The feature of Kwashiorkor like severe edema and of feet and legs, and also hands, lower and abdomen and face also, and is a pale skin and hair. The child is unhappy. There are also signs of marasmus, wasting of limbs, of upper arms, shoulders, chest, so that you can see the ribs. Nutritional dwarfing. Some children adapt to prolonged insufficiency of food, energy and protein by marked retardation of growth. Weight and height are both reduced and in the same proportion so that they appear superficially normal. Underweight child. Children with a subclinical protein energy malnutrition can be detected by their weight for the age or weight for the height, which is significantly below the risk. The risk for the respiratory and gastric infections. Treatment divided into 3 stages. Resolving life-threatening conditions, including correction of hypothermia, hypoglycemia, infection, dehydration, electrolyte imbalance, anemia, and other vitamin and mineral deficiency management. Restoring nutritional status. Dietary management includes the diet should be from locally available staple food, is expensive and easily digestible, evenly distributed throughout the day, and increases the number of feeding to increase the quantity of food. Ensuring the nutritional rehabilitation includes the concept of nutritional rehabilitation is based on the practical nutrition training for mothers, in which they learn by feeding the children back to health under the supervision and using the local food. Prevention, promotion of breastfeeding, development of low-cost weaning, nutritional education, promotion of correct feeding practices, and family planning and spacing of births, immunization, food fortification, early diagnosis. Thank you for your patient listening.